Good evening, everyone. Thank you very much for coming along this evening. As the title may suggest, I can't really cover everything, obviously, in one evening. So I was given a brief by an osteopath to say that don't talk about operations and things that we don't really get involved with. Talk about stuff that we see more day to day, which I thought was more relevant. So that's what I've tried to do, concentrate on those things. If there's any glaring omissions, and there will be, because I can't cover all hip and knee problems in one session, then feel free to take up a hand and we can discuss things. If it's knee related, I'll do my best to answer it. If it's outside the territory of the knee, I might come over all glazed and you'll have to forgive me. But anyway, we'll do our best. So I thought, where do we start? We're talking about common ailments. Where on earth do we start? So, like I mentioned, my wife is an osteopath, so do not tell us about ridiculously complex fracture patterns, because that's not really relevant to what we're doing. So, we'll talk about things that you frequently see in your practice, most of which doesn't require operations. There's the majority of injuries that don't need operations. And from that point of view, you guys see a lot more of these sorts of things than I do. I see this sort of tiny spectrum of it all. So, as I say, I work in Tunbridge Wells. I'm a consultant orthopaedic surgeon. I mainly do knees. That's my sort of main practice, apart from when I'm on call. And trauma-wise, I will fix most things as long as it's not a shoulder or a spine, or a complex an ankle thing. But when we're on call for trauma, we're on call for general trauma. Electively, I just do knees, orthopaedic general trauma. I instruct on an ATLS course in Tunbridge Wells twice a year. And this is a shot when we were out just before Christmas in Malawi doing a little bit of trauma out there, and I took a couple of registrars between Tots and the registrar out there. So that's my bit of background. So really, I won't venture above the waist if that's okay. We'll stick to hips and knees this evening. So we'll talk a little bit about hip pain and hip pathology. So when we're talking about that, we have to be absolutely specific about what people mean by hip, because lots of patients say, "What's my hip?" and then they point to their iliac crest or lumbar region. So hip is very specific. We're talking about the hip joint itself, okay? And I'm not talking about going into suck heads, but we all know that the hip joint itself is actually in the groin. The ball and socket is right there, almost under the femoral pulse in the groin. So we've got to be absolutely clear about what we're talking about when we say the hip and the hip joint. And of course, the problem with the hip is that there's a big overlap with lumbar pathology and referred pain. So we always have to bear that in mind. Is the lumbar spine the problem here? Is it the hip itself? Or is it something even completely outside of the musculoskeletal system? Is there a hernia? Is there something else? Is there a lymph node there that's causing the problem? And therefore, examining the patient is paramount. Examining the hip joint is critical, and we'll hopefully go on and discuss that later. So when we talk about hip pains, hip pathologies, we've got the tendinopathies and the bursitis, which we'll discuss. Impingement syndromes, I'm not going to touch on that so much, that's fairly specialist stuff, and hip arthroscopy is definitely on the increase, and hip surgeons are doing that. You guys probably see that a lot more than I do in a clinic, and I know it's common, but I haven't discussed that too much this evening. Arthritis, of course, that's very common. We all see hip arthritis, it's very, very prevalent. Fractures, I'm going to mention fractures briefly. I know the classic old person who falls and breaks their hip doesn't generally come to your clinics in primary care, but occasionally you'll get one which maybe is under the radar and might limp into your clinic saying, I've got a problem with my knee or my hip. So I'll mention that later on. And then we've got to think, as I mentioned earlier, all the sore hip bits in inverted commas that aren't actually the hip, and how to determine what's what. So we all see, well, I'm sure you all see a lot more of this than I do, but trochanteric bursitis, that's a common condition, isn't it? Classically, pain right over the trochanter, right? And that's because the trochanteric bursa sits there. And here it is. A couple of bursae. The gluteus minimus and the gluteus medius, as you all know, insert onto the greater trochanter. It's easy to palpate in any body habitus person. And the tender right specifically on that point. They often complain of pain radiating down the ITB towards the knee, and they often describe the discomfort when lying in bed. They don't like lying on that side. Here's the pattern. So we get classic radiation from the origin down the ITB towards the lateral aspect of the knee. When you examine them, it's much easier to have them in the lateral decubitus position, to have them on their side, bad side up, and you palpate onto the trochanter, and it's just behind the trochanter where the gluteus come and insert onto the bone. You have a fan-like insertion, and it's just posteriorly where they tend to be classically sore. You can find a definite sore spot there. If you're not quite sure, then you can A-B duct the thigh. That's called Ober's test. So you have them lying on the side, get them to lift up, and that's using their A-B ductors. So they're tensing the abductors, and then you can palpate again and see if that evokes pain. And actually, Ober's test involves bending and straightening the knee. So you tense the fascia lata by extending the knee, and that can reproduce their symptoms. Okay, so but important to get them in the lateral position with it bad side up. Imaging, well, it's a clinical diagnosis. Sorry. There's not really any scans. I mean, sometimes we can do MRI scans that might show little partial tears or detachments of the insertion point. But generally speaking, you don't need X-rays, you don't need ultrasounds. It's a clinical diagnosis. If they describe it and you prod them there, and that's where they're sore, the chances are that you've got the diagnosis. Of course, there's always exceptions to everything. So, treatment options. Well, the treatment options really start with hands-on therapy, what you guys do every day. Stretching, manipulating, massaging, etc. Whether or not there's a rule for ice, I'm not sure, but cryotherapy certainly works for many musculoskeletal ailments. Painkillers, of course. And then, when we're starting to get a little bit more invasive, then we can talk about injections. Anti-inflammatories, either taken as tablet form, or we can inject into the bursa and around the gluteal region itself, and that's a relatively easy thing to do in clinic, and sometimes with quite impressive results. Taping. I mean, I don't know much about taping. I don't do it as part of my practice. You lot know much more about that than I do, but taping is certainly an option for trochanteric bursitis as well. So here we've got someone lying down. I put a little bit of local anaesthetic in the skin. I use quite a long needle depending on the size of the patient. And you really want to get down, and I like to try and just touch the trochanter. I know I'm on the bone, then withdraw a little bit and give a good sort of 20 mils of anaesthetic and about 80 milligrams of steroid to see if that helps. And often that can either knock things on the head or give them a good kickstart so you can start doing a bit more physical therapy. I've never operated on a trochanteric bursitis that's recalcitrant to other treatments. A couple of colleagues have, and probably mixed results, but there's a Z-plasty type of operation where you can essentially decompress the fascia lata, but I mean, this is rare stuff. And some of the guys now are doing it arthroscopically because hip arthroscopy, as I say, is going through a sort of expansion just now. Okay, so that's the sort of tendinopathy things around there. You know, I know there's things like the iliopsoas impingement syndromes. They're much rarer things that I haven't really discussed or mentioned in any detail this evening. We can talk about this later if you like. So, good old hip arthritis. Hugely common. And really, it's only the most severe cases, or the ones that don't respond to your treatments, that end up coming to see a hip surgeon or an orthopedic surgeon. So the vast majority of arthritis, in fact, is dealt with in primary care. You see more than we do. So the history is, usually fairly classic. We'll go through it. So again, they say my hip is sore, but the number of times I'm referred patients for a hip replacement with hip pain, and in fact it's trochanteric bursitis, or there can be lumbar problems. So make sure you pin down and ask the patient where the pain is before going further. And classically with hip arthritis, it's groin pain or buttock pain, and it really is generally into the proximal thigh down towards the knee. Okay, they're the classic places: groin, buttock, and down the thigh. Associated with prolonged periods of standing, walking, you tend to find that their walking distance is limited, or in the early stages of the process, they might be sporty and they find that a game of tennis or going for a run is more and more difficult. They can't quite manage the 5K they used to be able to do, or they can't manage a full match of tennis or whatever it is. I'll put in toenails. So another early feature is that they have a restriction in internal rotation. So if they're sitting on the bed putting their socks on, or cutting their toenails, or drawing between their toes, if you specifically ask them about that, they'll say, no, I don't like doing that actually, because you've got to be quite flex, you've got to flex your hip quite far to be able to get down to your toes. So, or do your shoelaces up. So I ask them about that. And then coming on to the hip examination. So have the patient Recumbent on the couch, and like everything in orthopaedics, it's look, feel, move. Moving through a range of motions, so from full extension if you can. Thomas's test. Aware of Thomas's test? Thomas's test is a test for a fixed flexion deformity. And the point of a Thomas's test, you've got to have them lying flat on a bed, and you've got to eradicate the lumbar lordosis. Okay, so you get them to pull the other leg up. And as they do that, you've got to have your hand under their lumbar spine. And as they pull their contralateral leg up, you feel the lumbar lordosis disappearing. So then you know, when you look at the affected hip, if you've got a deformity there, that's a true fixed flexion deformity. Okay, so that's Thomas's test. You can be caught out, however, because unfortunately people aren't always textbook, and they may have hip arthritis and knee arthritis on the same side. Okay, so you've got to be a little bit careful of that. Is the flexion deformity coming from the knee or the hip? And the way to tell that is if you just put the femur flat on the bed, have the buttock here, have the knee on the edge of the couch. If the knee can go straight in that position, then the flexion deformity is coming from the hip. One of the earliest signs of even early arthritic change in the hip is a loss of internal rotation, which is why I chose this diagram. So you've got the hip flexed to 90, the knee flexed to 90, and then you bring the patient's foot towards you, and that can be an early sign, and that, they don't like that, or it's restricted in its motion. So it's either stiff or it's very painful when you do that. Okay? It's quite a good marker. So treatment, well, it's symptomatic treatment. We can't really change the natural history of arthritis, unfortunately, unless we can get them to do these other things. So it's symptomatic treatment. So, yeah, okay, painkillers, that's very straightforward. Weight loss, huge reduction in the joint reaction forces in the hip and the knee if you lose just a little bit of weight, because as we stand, as you all know, it's not my hip, it's not my body weight going through my hip, it's several orders of magnitude greater than that going through the hip and the knee. So if you even lose, I say to patients, if you can even lose half a stone, it's about 6 or 7 stone you're taking off your knee or off your hip. So remind them of that, because they quite like that. So give them a little goal. Let's say you lose 7 stones, that's quite hard. But it's good to let them know that just a small amount of weight loss takes a lot of pressure off the joints. And then, of course, maintaining range of motion and muscle power for as long as possible to protect the joint and delay surgery if possible. So when do you refer them to this guy? So I don't do hip surgery, I only do knees, but this is Mr. V, Mr. Deliudum, one of my colleagues in Tunbridge Hospital, a fantastic hip surgeon, in case you didn't know from. I asked him to do my dad's hip replacement, and he did it very well. But he's great. So when do you refer them on? Well, if what you're doing isn't working, you've given it a good 2-3 months of treatment, we're not winning. If the symptoms are really severe, if you see an x-ray and it shows dreadful arthritis, you think, well, I'm not really going to be able to win here. Or if you just want a second opinion and see what's going on here. So that's when I would suggest referring. But as I say, the majority of these patients are treated in primary care by yourselves. Okay, so then we've got to think about hip pain, in inverted commas, that isn't coming from the hip. So here's a picture of what looks like a failed hernia repair, a little scar there. But groin lumps, hernias particularly, can give groin discomfort, which may manifest itself as a hip pain. The lumbar spine, of course, I mean, you'll know that the lumbar spine refers itself and can refer pathologies to the hip, so people can complain bitterly of hip or knee pain, and in fact the problem is further upstream centrally in the lumbar spine. And then, of course, the weird, the wonderful, but always have in the back of your mind, especially for patients, elderly or other systemic symptoms and red flags, is this a metastatic problem? Because the hip's quite a common place to get metastatic deposits in the trochanteric region. And it's fairly regularly in our morning meetings in the trust. Someone comes in with hip pain, and we see a dreadful x-ray like that, and you know that that's terrible news, that's metastatic disease. So this is a pagetoid pelvis, but this is metastatic. You can see how the cancer is eroded. There's the cortices normally there, and in the subtrochanteric region there, you've got scalloping. This is an impending fracture, just about to crack and fracture here. So just have that in mind. I mentioned earlier, hip fractures classically are, elderly patient falls over in the street or in a nursing home or at home in the garden, whatever it is, they can't get up, and ambulance brings them in, and it's diagnosed. But occasionally there's someone who'll fall over, shuffle back into their chair owned by the ambulance crew, or their joint owned by their relatives, and they'll walk for a day or two or three or a week even, until they represent. So they may come into your clinics, because they're still ambulatory. And it might not be that obvious. And they won't have a classically short and externally rotated leg necessarily that you read about in textbooks. So it's really important to think about fractures. If there's been a history of a trauma, have a look at them, examine the trochanter. There's often ecchymosis or bruising by the suggested fallen. And when you examine them, flexion and internal rotation, I guarantee, will be painful. Okay, that's the movement. The flexion and internal rotation, that will really hurt because there'll be a big hemarthrosis, and that capsule will be stretched, and that's the one movement they really don't like. And the other one is axial compression. Okay, you can stand at the bottom of the bed, and with the knee extended, just push, just compress the hip joint. Right? And they don't like that either. Direct pressure over the trochanter as well can sometimes provoke the pain. But usually, if you examine them, it's fairly clear. Obviously, if they've got dementia or other problems, then it can be sometimes confusing. But even the most demented patients will wail out if you examine them and move them around a bit, which seems a bit cruel. If we're sometimes still not sure, we can see X-rays a week apart, and we're still not sure, then we tend to image them further and get a CT scan or an MRI scan to confirm before we take them to theatre. So occasionally, but not obvious, usually a history of trauma, examine them. That's the way to find out. And if you're worried, send them up for an X-ray. So that's not my specialist subject, hips. So feel free to ask questions, or we can do questions at the end. We'll come to something far more interesting, which is knee. By the way, I forgot to mention at the start, there's two sixth form lads at the back of the hall who are keen to become doctors for some reason. I'm trying to talk them out of it, but they want to go to medical school. And so they've come along to listen, and they've volunteered their knees up and hips for examination. I promise them nothing else. So, with a hearty minute of them. If you want to go through any examination techniques at the end, then we can do that if you like. With examination cash, we can go through testing. So, knee pain. So how to cover knee pain in the short amount of time we've been given? Well, I've tried to pick up common things and things that you're more likely to see than I'm more likely to see and discuss those, okay? I've also picked a couple of things that I... So, pathologies. So with knee, we've got all the soft tissues, so we've got ligamentous problems, we've got cartilaginous problems, the menisci, which I haven't really discussed, I've discussed that in other talks here before, and inflammatory things. So I haven't really gone into the rheumatoid type things or the psoriatic arthropathy. So that's not really the purpose of this evening. So I mentioned briefly ligament injuries, which is a little bit in a while. So arthritis, again, we all see lots of arthritis. It's very, very common. So we'll talk a little bit about that. And then we can talk about the things that happen outside the knee, not necessarily the joint. And then, of course, the non-knee knee, so the referred pain, so the hip pain presenting as knee problems, or other types of pathologies. So, medial collateral ligament, the most commonly injured ligament in the knee by a country mile. It's very, very common to injure the MCL, and the majority of them are grade 1s and grade 2s. They're usually associated with a valgus type of injury, okay? So either a direct blow from the side, forcing the knee into what we call the valgus or the knock knee position. And as a result, you put a tension force on the medial collateral ligament. Lateral blow. The other one is falling down the stairs. It's quite common. So people who fall and then twist and you have their feet caught behind them, and that puts them into that valgus position. But they won't necessarily remember the knee doing that. But falling down the stairs in the elbow is quite a common way to injure the MCL. And they're graded 1 to 3, so 0 to 5 millimetres of opening in valgus, 5 to 10 for a grade 2, and more than 10 millimetres is a grade 2. There's different ways. Traditionally, it was described as just a bit of pain and stretch, but no laxity in the joint. A second degree sprain was a partially intact fibres, but a little bit of laxity. And then the grade 3 was the complete rupture, where you get significant opening of the joint. So when you examine them, by far and away the most important bit to press on them is the medial epicondyle. Okay, so that's the origin of the MCL on the femur. And that's where the huge majority of them happen. The complete tears are usually mid-substance. Very occasionally you'll see a distal MCL. So where it's quite low down on the tibia, posteriorly. They're very, very rare to get those injuries. They do exist. but they're not usually that painful, interestingly. So by far away the most common place to see them is up at the epicondyle, and that's where you've got to press, and they really don't like that. So feel around the tibia, feel around the joint line, because the deep MCL, remember, and sets into the joint line, but the superficial MCL continues much further down the tibia. And then do a stress test. So the stress test is the valgus, so about 15 to 20 degrees of valgus, flexion. You're putting a valgus strain on the knee, and what you're feeling for is how much opening there is, and then comparing that to the other non-injured side. It's really important to get a side-to-side difference, because some people will be very lax anyway. So you've got to have an idea in your mind of what's normal for them, and then compare the two. And then you can offer a grading depending on how much you think is open. Let's see if I can get this video to run. It's a bit easier when they're asleep in theatre. So you can see how much bruising there is in this guy's knee as a ski injury. A lot of bruising medially, and you see all the bruising lateral as well. So he's had a big injury to his knee. He's had multiple injuries. But I showed you this because I thought it would be interesting to see what his MCL is doing. How much I saw. And you notice I did that in about 20 degrees of flexion. He's the normal side. And that's how much he's meant to have. Okay, so he was on the table for an MCL reconstruction. So treatment of MCL injuries. So in the acute phase, rice. You can't really go wrong with anti-inflammatories, ice and compression and bandaging, etc. Okay, so get on nice and early. And then you're working really to restore the range of motion after that. Building up strength with all the muscles around the knee. And then you've got a little picture here of a brace. So the grade 2s and really the grade 3s, the ones where you've got a lot of opening, I put them into an extension blocking splint straight away. And the reason I do that is that if you extend your knee fully, your MCL is taut, maximally taut in full extension. So if you've got an injured ligament, you want to try and take some of that tension off. So other fibres to overlap in here. So if you stop them coming to full extension, you can allow those fibres to heal. And a grade 3, I mean, it's the best healing ligament in the body, the MCL. It will heal very well in the majority of cases. Unless it's distal, which is a slight side. So put them into a split that stops them fully extending. I put them at about 20 to 30 degrees of full extension blocking splint. They can flex as much as they like, because that creates more laxity. It's the full extension you want to try and avoid. Okay, so that's what I do when I get them nice and early. Keep them there for about 4 to 6 weeks perhaps, let them fully wait there. And if they're grossly unstable or don't heal up, then that's fine, that's going to be time to refer them on. I don't really acutely repair MCLs unless it's in combination with another injury. So if I have someone who's got skier, for example, for a footballer with an ACL injury and a complete MCL rupture, then if they're coming for the surgery, I will repair or reconstruct the MCL. The ACL is more than we see them, sadly. So really, in the acute setting, if there's an injury to the knee and the knee's full of blood, then in my book, that's an ACL rupture until you've proven otherwise. Okay, so you've got to have it really at the forefront of your mind, especially in the winter season with the skiing, but all year round, footballers, rugby players, netball players, hockey players, cricketers, cyclists, trampolinists, landing from jumps, people who jump on the fences in a drunk, you name it, it's happened. It's a very, very common injury. So just think, if there's an acute injury and a big swollen knee, think ACL. Because I would like to refer them on as soon as possible, if you can. I'm not saying they all need operations, because they don't, but they are common. So, the classic history in an ACL injury, hyperextension. So, netball player goes up to shoot a basket. As they land on an extended knee, and then they back knee. Okay, because the ACL was very taut in full extension. Rugby players get lifted up in the lineouts by the props, then once they've got the ball, the props let go of them, and they come down and hyperextend. Hurdlers can hyperextend as they land. Twisting. So, for the last few months of my knee injury clinic on a Wednesday morning in the trust, a number of people coming out from the French Alps who have even gone down at a very slow pace. But because the lever on a huge, big, long ski, if you twist the toe of the ski, then the moment arm on your knee and the taut there is huge. So twisting injuries, very common to rupture the ACL. Valgus, so people who get challenged in football, and a sliding tackle from the side. Remember the MCL is at risk there, but the ACL then goes as well. If you have a big valgus injury, you have a potential for an ACL rupture or injury. And landing we mentioned. Apologies for this one, if you've just had supper. Is there any, can we get a sign for work, Georgie? Is that on my phone? No. So, horrible injury. And that's an extreme, they're not all like that. That was a dislocated one. So, sorry, you have to look at that again, please. So they often say there was a pop. If they have an injury and there was a pop, then that's got to be one of two things. It's an ACL, or occasionally it can be a patellar dislocation. Okay? But if they have a big injury, a valgus, a twist, hyperextension, land from a jump, and they feel a pop, boom, something in your brain has to say, right, this is an ACL injury. Crunch. They sometimes describe a double crunch, and I think what happens when the ACL ruptures, the femur and the tibia, you essentially have a hemi-knee dislocation. So the condyle of the femur laterally jumps back down onto the back of the tibia, and then it bounces back in again. So I think the double crunch is the initial dislocation and the relocation. But they often say there's two crunches. Now, it doesn't come out, but the double fisted side, if they say to you, my knee sort of did this, as soon as they put the two fists together and do that, that is pathognomonic for an ACL rupture. It can't be anything else. Okay, so it doesn't happen very often, but when they do, you know the diagnosis straight away. They say, well, my lower part of my shin did this, and the thigh stayed behind. So look at that. So that's the acute setting, and then the instability is what they then present us. They don't really complain of pain as such with an acute ACL. Yes, that's sore. But after the first 3-4 weeks, even if you don't do anything to them, they generally settle. The swelling comes down, and they start regaining a range of motion. And some of them say, actually, it feels fine. They might be referred early. By the time I get to see them, sometimes there's actually no symptomatic instability. But if you press them further, say, well, have you gone back to sport? Have you gone back to football? When I'm talking 6 months, a year down the line, that's when they say, well, I tried, but my knee just collapsed. I turned the corner and it collapsed on me, and it all swelled up again. And the problem with an unstable knee, on occasion, is that you can run further injury to the knee. So if you rupture your ACL, but you don't injure your meniscus at the time, if you then have an unstable knee for 6 months, a year, 2 years, 10 years, whatever it is, something else has to take up the slack in that knee. And the next structure to do that is the medial meniscus. Okay, so the lateral meniscus is the most commonly injured at the time of the injury because there's a valgus path of injuries. So the condyle comes down, and either the lateral meniscal root pulls out, or you get a bucket handle tear of the posterior horn, or you get radial tears at the junction of the posterior horn in the middle third. So the lateral meniscus is acutely injured. But longer term, it's the medial meniscus that takes up the slack of that defunctioned ACL. Okay, so I often see people come into my clinic who haven't had an ACL for whatever reason reconstructed, and they've got a flip bucket handle tear of the medial meniscus and an ACL deficiency, which is a bigger problem to sort out. So when we examine them, there's the three sort of classic tests that we know about. So the anterior draw, the Lachman, and the pivot shift. And of those three, I have to say, I find this reproducible most often, and that's what I tend to rely on. This, if it works, if it's positive, it's 100%. So if there's a pivot shift positive knee, 100% that ACL is ruptured. So it's very sensitive. The problem with the pivot shift is that it's quite an uncomfortable sensation for the patient to have. So if you can get them to relax, and you get one chance sometimes, because otherwise they'll spasm, they won't let you do it again. If you get a positive pivot shift, then you're on the way, you know exactly the diagnosis. It's much easier to do when they're asleep, of course, and I know in primary care that's a bit harder. The anterior draw and the posterior draw is in the textbooks. I have to say, I don't use it that often. I think I've got a little slide to show you. Here's one that here's a little anterior draw test, just to show you what you can see. There's my thumbs on this tibia, We go forward. So that's normal, that's coming forward. Normal, forward. Okay, so, I mean, that's pretty obvious, isn't it? Here's a pivot shift. So he's got ACL in his leg, so he's about to have an ACL reconstruction. So there's the Lockman. Now, extension, valgus, and my registrar asked me to do that again, so and that. So the knee extension, internal rotation of the hip, and a bit of valgus. You just watch the knee just pop about now. There it goes. So that's a pivot shift test. It doesn't have to be a great big horrible movement. It can be quite, it's only done in the first 15, 20 degrees of flexion. But if you get that, then you know 100% the ACL is not working. Even if there's a scan that shows it's intact, it ain't working.
Can I ask a question?
Yeah, sure.
That's the patient complaining of huge pain, or how much pain is the patient in?
Sorry?
How much pain is the patient in doing that test?
Well, so some people will lie and let you do it several times, and all the registrars come and all have a go. Okay, so they can be absolutely pain-free. And some will, as soon as you start putting that position, if their heckles go up, they spasm, and there's just no way you can do it. So it's a big spectrum. It's not so much painful as just an unpleasant experience. You don't, because what you're doing, I mean, essentially what a pivot shift test does, is we'll demonstrate with the lads later on if you like, but you're starting off in a dislocated position. So you're dislocating the knee halfway before you even start the test. So that's why you do the internal rotation and valgus. So you've already got it, and as the ITB flips over the condyle, the knee jumps back into socket and it reduces. So that clunk you're seeing is then falling back into joint. And that's apparently a very unpleasant sensation. And that's why they often don't like you doing it when they're awake. But you know, everyone's different, so sometimes they'll let you do it all the time and it doesn't bother them. I don't like the big clunky one because I'm worried about damaging other things the more often you do it. So I only let my registrar have a couple of shots in theatre when we start. Right. So, treatment of ACL injuries. Well, I'm a proponent, of course, of ACL reconstruction in the youngsters. Okay, so I think there's a big difference between older patients and young patients. So I think if you don't have symptomatic instability, it's quite difficult to justify doing an ACL reconstruction on someone. Okay, because really what we're doing is we're offering stability to the knee. But there is a but. Because I've seen 16-year-olds, 17-year-olds who've got an ACL rupture, who do not have unstable knees, maybe not that sporty. But we know that if you have an untreated ACL injury in a kid, by the time they're in their 40s, they will have grade 3 and grade 4 arthritis. There's a big paper out in the late 70s, early 80s, and something like 75% of patients at 30, a long-term follow-up, 30 years, had grade 3 and grade 4 arthritic changes in their knee. So, you know, you're on a hiding to nothing. Now, we don't have any evidence. We like to think as knee surgeons we're stopping arthritis progressing, but we probably don't. So I think the instant you rupture your ACL, the die is probably cast for arthritis. But what we think we can do is if we can limit the number of episodes of instability, then we can protect the menisci for longer, and therefore we might delay the onset. I think we can stop the arthritis happening, because on a microcellular level, I think once that impact has happened, if you see an MRI scan of someone who's just ruptured their ACL, the entire lateral condyle and central portion is just a whiteout. So you can imagine what the cells are like underneath that. And the same on the back of the tibia. So I think that for older patients, you've got to have someone who's got a symptomatically unstable knee, and they want to be able to go back to tennis, squash, badminton, netball, hockey, or it's so unstable that every time the kids say, "Mum," they turn around and their knee gives way. I think that's a reasonable thing to offer surgery for that. But with children and youngsters, I think that I would almost always advocate surgery in a protective, as a protection to stop the knee becoming unstable over the years, and then coming on with a displaced bugger handle to have the medial displaced that we talked about earlier. So the early treatment is rehab. So you've got to get that range of motion going, get the blood out the knee, get the muscles firing, and get a range of motion restored. And that's vital, regardless of whether we're doing an operation or not. It's still the same treatment. So prehab if you're having an operation, or rehab if you're not. And we aiming to get a range of motion restored as best we can. And I sometimes disappoint people by sending them away and away for surgery until they get a range of motion, because if If we operate on them too early, then it's very hard for them to regain the range of motion after the operation. So we really try and push as hard as we can to get the range of motion. Obviously, if the muscles around them, you have to be as strong as possible, particularly the hamstrings. And then the big question, and nobody knows the answer, is when do we let them go back to sport? 6 months? Some of the high-level athletes go back to sport 6 months. I personally don't let mine go back until 9 months. I think that the biology of the graft is not strong enough to put, so even if the muscles are good and they're feeling good, I don't think that the graft itself is mature enough to take the stresses and strains of high-level sport. So I have a 9-month single. Maybe I could push that, maybe I could push it earlier, but I don't want to increase my failure rate. So that's ACLs. Right, knee arthritis. Again, like hip arthritis, it's a huge, huge burden to the NHS and any healthcare system. And it's going to get more and more as well, as we'll live forever. So you all know what arthritis is, very common. And we're seeing it in people in their 30s and 40s upwards. It's quite alarming, but we're seeing it in youngsters as well. So I tend to have a sort of slightly bleaker view of the world. I see the ones that want to have an operation, need an operation. But the vast majority of the ones I never get to see, because arthritis starts in the 20s and 30s, and it's a spectrum. So in primary care, you see the vast majority of people with knee arthritis. So the classic history is stiffness, pain, limitation in the walking distance, instability. Instability is actually quite a common symptom in arthritis. And when I think about knee arthritis, there's two kind of types. You've got the varus arthritics, which is by far the most common, so that's the Charlie Chaplins with medial side of the way that we saw in the X-ray. And they tend to have pain as the predominant feature. It's just constant aching, dull pain, or terribly severe, depending on the patient. The valgus arthritics, the ones who are not kneed, their main symptom actually, they can be painful, but often you see dreadful X-rays. They don't have much pain, but they have a giving way, so they're unstable. And that's not to say that the varus ones aren't unstable, because they often are. But classically, with valgus arthritis, they have instability. They don't trust the knee, it doesn't give way, they don't like coming down the stairs. So that's something to sort of bear in mind when you look at someone who looks a bit like me. Is this valgus arthritis? So, treatment starts with finding the care things. So, working on range of motion, maintaining range of motion, getting the quads and the hammies and the glutes as strong as possible to protect that joint for as long as possible. This is one thing which I think is really important. The number of people who come to my clinic with dreadful arthritis in their 50s who are absolutely mad keen on running, for example. Sorry to be the bearer of bad news, mate, but if you carry on running, you're going to need a knee replacement pretty soon. So you have to tell them it's not up to us whether we pay attention to their advice. That's up to the patients. Their knee, they can do what they want. But I think you have to tell them that high impact things on arthritic knees and hips is only going to end one way. It's going to be badly, because the amount of force that goes through that already arthritic joint are huge if you run. So tell them there's lots of other sports they can do that are kinder to the joint. It might not be as much fun, but football, cutting, pivoting, twisting, landing from jump sports, much higher impact. Generally, you want to try and keep away from those if you can. It might not be very popular, just a mess with it. Weight loss, we mentioned that, and sorry to bang on about it, but it does make a difference. And then we can of course give them analgesia, and that's pretty obvious, anti-inflammatories. We can do injections, so 2 types of injections, so cortisone injections, evidence for it, not very good. No long-term studies showing it makes any difference. Some people think it's absolutely wonderful, and they come back for regular top-ups. I have a rule of about 4 years probably maximum. There's no good evidence in the literature to suggest that the more cortisone injections you have, A, the earlier you'll need a knee replacement, or B, your risk of an infection when you have a knee replacement. So there's no good evidence. So it's probably not a major deal, but I generally, as a rule, keep it to 4 cortisones per annum. I think the other thing to say is that if you get a good response to one, I'd prepare the patient, you'll probably have a 50% as good response the next time, and a 50% as good response the next time, and so on. So you've got to be realistic. But some people seem to respond to it better than others. And then, in the NHS, I'm afraid we cannot prescribe this. We can't get any of the CCGs to fund it. Again, there's no good big studies, despite what all the reps try and tell you, about viscous supplementation. So this is hyaluronic acid, is the active ingredient, which is on the articular cartilage molecule is the big long bit that soaks in the water. And they worked out what it is, and they can manufacture and put it in a test tube for us, and we can literally squirt it into the joint, and it's like a gloopy oil. It's a bit like, I call it Castrol GTX for the knee, if the patient seems to understand that, and they come back for their oiling every now and then. But unfortunately, it's not available on NHS yet. But I do a lot of in patients who are insured or take it myself. That's the one that I use particularly, Monovisc, only because it's got the highest dose of HA. But again, the evidence for it is a little bit shady, so I've really absolutely honest with the patients. And there's no strong evidence this is going to work. Anecdotally, it seems to work quite a lot. Offloading braces. So if you've got someone, so here's a knee, here's the lateral side because there's the fibula. So this is a classic Charlie Chaplin bow-legged medial-sided arthritis, constant aching and pain. Now, if you drew a plumb line from the centre of that patient's hip down to the centre of their ankle, so where their weight actually goes when they stand up, in the normal situation, our weight should go right through that little spike there, which is the medial tibial spine. See that thing there? That's where your ACL sits. And that is where your plumb line should go. But with this patient, as they lose cartilage on the inside, they become more bowed and more bowed. So the plumb line suddenly starts falling into the bad bit of the joint. So that means that they're putting more weight through the already warm bit of joint, which means it wears quicker, which means it becomes more varus, which means they put more weight through it. So it becomes a vicious circle. So once you get a varus knee, everyone happy with the term varus, and sit down if you don't. Once you become bow-legged, then that is just a descending pathway. Even in someone who's 30, who's got footballer's legs and footballer's knees, we know these guys are going to get arthritis because they are loading the medial compound. So, an offloading brace is put on above and below the knee, of course, and it puts them into valgus, so it pushes pressure that away. And it shifts the weight-bearing axis from the bad bit of the joint onto the relatively healthy bit of the joint, onto the lateral side. And the results can be quite remarkable. It's just annoying because you've got to wear the brace every day. But in fact, yesterday, on my list in the trust, I did an osteotomy on a guy who was 51, 52. He's had a brace on for 1 year, medial offloading brace, and he said it was just the best thing ever. He absolutely loves his brace. It's taken away his pain completely, but he just got fed up wearing the brace. And when I saw him and visited him with the brace, I said, look, try this, see how you get on. But that's what it's going to be like if you have an osteotomy. And he came and said, I want an osteotomy because it works. So he's only 24 hours down the line, so we'll let you know how it gets on. So, when you've done all the things that you can do, and that is going to look after most people, there'll be a few that slip through the net. The ones that don't respond, the really severely arthritic ones that really, whatever you do is not going to work. And then fine, send them on for surgery. So what operations can we do? So arthroscopy for arthritis, keyhole, scrape, wash up, tidy up. That is just a terrible operation, okay? And as my professor in Australia used to say, that operation in Australia has paid for more extensions, school fees and sports cars than any other operation. It's appalling to say that, isn't it? But it's true. I say to patients in the private hospital, there's only one person in this room who's going to benefit from the operation when they ask me for a washer. I tell them it's not you. So, and they sort of laugh and say, well, thank you for being honest, because it doesn't work. Okay? It does not work. There's no evidence to suggest it works. And in some cases, it can have catastrophic effects. Because if we go into a knee and you tidy up, whatever that means taking away the remaining bits of cartilage and bushing what's left, you can precipitate a terrible spiral of failure in the joint. So, the insurance companies now will not fund it, and rightfully so. And I think in the NHS, we're going to be coming, we'll catch them eventually. But myself and my new surgeon colleagues in the trust, we're very, very onto it. And you get onto the registrars if they try to list someone for an arthroscopy. It's a grey area. But for arthritis itself, a tidy up and a washout, I see some people who've had 7 or 8 tidy up, 3 operations. What's that mean? That's appalling. It doesn't work. So, I think I made that clear. Don't like arthroscopy in the knee or arthritis. However, this stuff works. It's just a lot more aggressive. So, this is the operation I did yesterday. Not the actual operation, but this is an osteotomy. So, we make a cut in the medial aspect of the tibia, and we essentially jack the bone open and leave a gap of up to 10, 12, 15 mils, depending on how big the deformity is. And we just do what the brace was doing. We put the weight onto the good bit of the knee. And the 75% 15-year survival rates on the big studies of that. So it's a great option for someone who's maybe a little bit on the young side. So the guy I did yesterday was 52. He wasn't really ready for a tin and plastic knee. He was still quite active, and he wanted something that he could maybe carry on well into his 60s and 70s with. Any youngster who's got deformity, then I'd advocate this operation. It's a fantastic operation. I think it fell out of favour in the 70s and 80s when they first started doing them, in the 60s and 70s really, because there was really quite a barbaric operation. We didn't have good ways of controlling the legs, so we could do the osteotomy, but then we put them in a plaster and hope that that held it in position. And it wasn't really an exact science, it was hit and miss, whether the damn thing healed, and if it healed, it in the right position. Whereas nowadays we've got these fabulous, in this plate, they're quite big, but they're fabulous, they're so well designed, and they can take full weight. Like in a big rugby player, I can get weight bearing straight away in that plate. And it compresses the fracture from the lateral hinge to the medial side. And you see the bone filling in, it's a big operation. But it's a big deal, it's an investment. You've got to get the patients on board. Because you basically you're literally breaking their leg. You have to recover. I can't spend, there are many complaints in and around the new children. But I will just mention one or two. So, common. Children knee pain, common. I see a lot of kids in my clinic with knee pain. And you do as well. It tends to be the sporty ones. It's not always, but it tends to be the ones who are trampolining and gymnastics and goodness knows what 4 or 5 times a week. So osteochondral disease, I'll have to talk about this a little bit. So it's a very common cause of pain in the adolescent. And it's pain just on the tibial tuberosity, where the patellar tendon takes its insertion on the proximal anterior aspect of the tibia. And it tends to be associated with activities. The more sport they do, the more they get discomfort. If they ease off the sport, it tends to go away. It's not rocket science. Here's the treatment. So mainly reassures, because it's a very common problem, and it doesn't have any long-term ill effects. From any of the studies that I've looked up and read about, there is no long-term problem. So it's just a symptomatic managing the problem whilst they go through skeletal maturity. It's just 13 to 15 years old. The classic age, and you have to just reassure them. You can do other things, of course, which is the normal things, so rest, ice, compression, etc. And something I try to tell them what to do is, not everyone knows to warm up, and most people know that. The warming down afterwards is quite important, I think. So, level evidence 0, okay, but it's something that an old paediatric surgeon told me many years ago. Get them to warm down, because none of them do that. So that's what I try to reinforce. So, setting off games is, and banning a kid who loves their sport and does sport 4 or 5 times a week, it's quite a difficult sell. And to be honest, we're only kidding ourselves if we think they're going to pay the slightest bit of attention to us. Because this is not generally debilitating pain. This is just aching and discomfort. And they mention it to mum enough times, they drag them along just to get checked over, and that's generally what happens. So it's not debilitating pain, but the mum gets fed up with whinging after the game of football or netball. So they bring them along so they can something in his leg. He said, well, this is osteochondritis, and he'll go out of it, she'll go out of it, don't worry. However, they might end up with a bump. Okay, so most of them do end up with a bump in dadhood, so that's cosmetic. Occasionally that can cause problems with kneeling. So if they're going to an electrician or a lay preacher or something to work on your knees, could be a problem. But the majority settle down. The American Academy have, in their advice on the treatment of osteochondritis, is to limit activity. So it doesn't say stop activity, it says limit them. So you have to have a bit of a sensible conversation. If you're playing sport 5 times a week and you're not skeletally mature, that's probably too much for a skeleton, that's telling you something. So that's the approach I take. So maybe go down to 2 or 3 times a week. Or change a high impact activity from running to swimming or something like that. That's what I tend to say, and it will rise it a bit. If you look at all the long-term studies, they're all retrospective, so there's no prospective randomized control trial for osteochondritis, but they all say the same thing. The message is the vast majority of them respond to limitation of activities and anti-inflammatories. Occasionally get one that don't settle, and if there's an ossicle, so if we scan them, and there's a little ossicle which is like a little bit of bone within the tibial tuberosity itself, for some reason they do other surgery. I have to say I had a guy who persuaded me to do it when he was 19. He'd had osteochondritis disease in his early teens, and he had definite tenderness over the tuberosity, and I scanned him to make sure there was nothing strange, and there's a little ossicle. And I was very sceptical about whether it would work or not. And we did it, and he was absolutely delighted. So, and the studies do suggest that they do work. If there's a nostril there, we can take them out. But that's pretty rare. So please don't send all the musculature above to us unless they're really symptomatic. And again, the take-home message is don't tell them to stop playing sport. Warm up, warm down, maybe slow down a bit. And there's no control trial, so there's your chance, guys. If you listen at the back, do a prospective randomised control trial, we're going to medical school now. Right, sending lasting Hansen syndrome. So this is again traction apophysitis. It's the other end of the patella tendon. So this is where the its origin, the inferior pole of the patella, and you get fragmentation of the X-ray, and you get classical pain at the lower end of the patella. I'm not sure if this is on your handout, so apologies. I think I made an amendment this morning to my talk, so it might be on your handout. So again, much less common than osteochondritis, but it's an obese syndrome, a traction apophysitis. So where the cartilage is becoming bone, it's a weak point, and that's where they get pain. Classically, 10 to 30-year-old males, and the treatment is very similar, as I say, to osteochondritis. It's activity modification, anti-inflammatories, and they do settle down. I suppose the nearest thing to that in adulthood is patellotendinopathy or jumper's knee. Right? But remember, this is not a degenerate process. This is children, so children don't degenerate. We degenerate, I'm afraid, in this room. That was the exception of those two at the back. Those three at the back. But it's a similar area and similar clinical findings. Tenderness at the origin of the patellar tendon when it comes up the inferior pole of the patella. When you examine them, and this goes for adults as well with jumper's knee, it's very important to have the knee extended because when they're flexed, if you don't flex your knee, the patellar tendon is really taut, and the deep fibres tend to be the area where the problem is. So you can't really make a meaningful assessment with the knee inflection. So you extend the knee, it slackens and detension of the patellar ligament, and then you can prod your thumb and you get a definite response to that. Okay, we are done, I think, in terms of my bit. I'm more than happy to take questions about anything relevant. And this is just a quick plug. We started doing a little sort of private acute trauma service in the Spa Hospital. So myself, a shoulder colleague and a foot and ankle colleague are hoping to see acute injuries for those people who are insured or don't want to wait for virtual fracture clinic to call them back. So the numbers at the bottom, and George can give you some information. I think there's something in your packs, is the George. So if someone wants to see one of us, quickly, there's a self-pay price and they get a scan and get seen by a consultant as one package. Thank you very much.
I just have a question about when you perform the osteotomy. When you perform your osteotomy on the knee, how do you do any kind of measurements between your left and the right knee? And how would you do it to make sure that they stay stable?
Yeah, absolutely. So very good question. So it is absolutely critical. So I just showed you the end product, but there is so what we have to do is get special X-rays called long leg alignment views. So that's an X-ray where you have the hip, the knees, and the ankles all on the same X-ray, and then we can draw a plumb line, so a plumb line is a piece of string with a stone going down the end. If you put it over the centre of someone's hip joint and drop it down to the middle of the ankle joint, that line should go through the medial tibial spine like I showed you on that X-ray. Yeah. So depending on how far away from that medial tibial spine is how deformed the deformity, right? So you've got to measure the deformity. So you measure the alignment, you know where the deformity is, and then you can calculate where you want to put the new axis. So I pick a point on the plateau. I normally put them just over halfway, so I'm just putting them into valgus. You don't want to overcorrect them because we won't thank you if they overlap for the rest of their days. So you want to bring them to from varus to just beyond neutral, so that the weight is pulling just in that. Now the way to do that is you draw a line from the middle of the hip to the new weight bearing axis where you want to put them, and then those two lines at the bottom form an angle. If you draw an angle at the hinge point on the lateral side of the tibia between those 2 points, that angle you measure is the angle you've got to open by. And then there's a little table of trigonometry. So you can calculate how many millimetres of opening you have to do. Now that's how we used to do it with measurements, but there's a fantastic bit of software now which makes it very easy. So we still need the X-ray, but there's a lovely bit of software that once I've drawn in the lines, I can literally with a mouse click and I can break someone's leg and just shift it as much as I want on the X-ray on the computer, and it tells me exactly how many millimetres I need to open them by. So yesterday the guy was 7.5 millimetres of opening to make him. He wasn't like hugely deformed, various deformity. So it was a fairly small correction, 7.5 mils. Biggest one I've done is 15 mils. So this guy, he barely walked, he was like that. And I was a bit worried about him because he was a smoker as well. And I opened up 1.5 centimetres. So there was a huge big gap between the two bones. And I was worried about him not healing, but in fact, he healed up. He had the other side done by his father a few years before that. And so he's now got straight legs. So that's how we do it. It's software essentially. It's some really nice software. It tells us exactly where to do it. And it tells us what the angles are going to be as well. So it's not just a case of, because we optimise the femur as well. So for people who've got knock knees, if you've got a 50-year-old who's got a big valgus deformity like that, you might not necessarily want to do a knee replacement something that young. So we can also optimise the femur, but the software tells you the angles of the joint. So if you do that, you don't want to tip the joint into too much varus or valgus, otherwise you won't be happy. So the deformity is either in the femur or the tibia, and very occasionally in both, in which case you have to do a double osteotomy.
Does the book as well on discrepancy of length as well?
Not so much. I mean, the length discrepancy you have, if they're valgus or varus, is just because of the angle. Once you've restored that, I do an opening wedge osteotomy, so that one I showed you. So that all you're doing is restoring the deformity. So in fact, they don't gain any height. You can do a closing lateral osteotomy, so it has the same effect. And then you really do shorten the height. I mean, they lose height if they do that, but I don't do that operation.
With a stable ACL or MCL injury, and the patients are told not to have surgery because it's stable, and just told to strengthen it and they're strongly into tennis and squash. My concern is kind of 20 years down the line, they're not going to suffer when their muscle tone slackens. Are they then going to?
So yeah, I mean that's the grey area of it. We don't know is the answer to that. I mean they don't generally slacken. I mean they're either going to be stable early on once they've had some rehab, or they're not. So if I get someone who's maybe 50, skis once a year, doesn't really do much other sport other than that, and they come in off the ski slopes having ruptured their ACL, I'll say, well, look, what do you want to do? And they say, well, I want to be able to ski again. Fine, you don't need an ACL to ski. So that's a big myth. So yes, loads of people rupture their ACL skiing, but you don't need an ACL to ski. So I say, well, do you play netball? Do you play hockey? Do you do any cutting, pivoting, twisting sports? If the answer is no, then generally I say, well, why don't you go and have some rehab? Work on your hammies and your quads and see how your knee fares. And we'll catch you in 3 months. And if your knee's unstable, we can talk about surgery. If it's not, you can hold off. I don't think there's a major problem in the 50s and 60-year-olds who I see, and that's generally advice I give them. Unless they come in and they're senior tennis players and they come in already telling me what they can do. That's different. That's fine. But generally I would say try a period of non-operative treatment. I'm not aware of slacking off of anything. We get a bit weaker as we get older, we know that. But we also play a bit of sport with it in the 60s and 70s, so it's probably not so much of an issue. The ones that I would sort of preemptively reconstruct, so all completely immature children get an operation, even though they're a couch potato, because we know that the literature suggests that if you don't do something, you're in big trouble in the 30s and 40s. So they're the ones that I say to parents, no, I know he doesn't need sport, he had a slip on the ice, he was unlucky, but I would advocate at his age, he's 15, we should stabilise his knee. And then this sort of grey area, maybe sort of 25s to 40-year-olds, and occasionally do sport, not symptomatic, that unstable, but you're worried about the menisci. So I just have that conversation with them. I say, look, I see a lot of people come into this room who didn't have their ACL reconstructed for whatever reason, they were advised not to, they didn't want to at the time, and they come back in worse off because something else has failed. So it's tempting them to maybe say, well, should I be doing it to then stop that happening in the future? But also I think you have to tell them that we're not going to stop the natural progression of arthritic change in the knee. We might affect the rate at which that happens. Yeah.
Do you ever use the Lely's test for the ACL?
The
Lely's test?
You have to tell me what that is, I don't know.
I think you put your fist under your gastrocs and then push down on the femur. So if the heel raises up, the heel doesn't raise off.
Okay, so that sounds a bit like a lock with a different pivot.
Okay.
I mean, what we're trying to do is seeing if the tibia moves anterior relative to the femur. I think with it, we can go through the Lockman test, the one I find most sensitive. I think with the Lockman is your non-examining hand is the stabilising hand. That's the one that goes on the distal femur, and that's got to stay steady. So you keep that rigid, and you've got a huge big rugby player. Sometimes I have to use my thigh and get the rest of the thigh on mine just to stabilise it. Put my hand on top, because my hand can't go around some of the odd monsters you get. And then with the examining hand on the tibia, the direction that I was told in my fellowship is you're trying to pull their tibia over your shoulder. So that's the direction of travel. I can show you a video. You can certainly practice them on the lads if you like. Much harder. So get them nice and relaxed in a position so you're not going to hurt them. Now, first thing I do is look for an effusion. Okay, now sometimes it's glaringly obvious, huge big knee, and you don't need to be a rocket scientist to work that out. For the more subtle effusions, I find the sweep test is the most sensitive. Okay, so I sweep. So remember, the capsule starts at the joint. The joint line is where the capsule inserts. See some people doing this kind of thing, and think, well, that doesn't really make sense. The joint capsule starts here, and it comes quite far up to well above the superior pole of the patella. And you want to sweep medially, so any fluid that may be present is going up the medial gutter, into the suprapatellar pouch, and into the lateral gutter. You then compress at the top, and you're just pushing on the lateral aspect. And you're looking here for a little bulge. Okay? And it's really sensitive. You can just sweep, and then just do a little push there, and you can see it bulging. So that's the way I do it. The Ballock test, we can do the basketball in the pool of water. That's really for a huge effusion. It's pretty obvious if that's the case. So that's the test I find the most useful for an effusion. Okay? It's a very sensitive way of knowing there's something going on underneath. There's water underneath, there's something going on underneath. Okay? You can't make that up. Right. McMurray's. Now, McMurray's test is described in many different ways in all the textbooks. Okay? And you have to find your own way, because there isn't really a wrong and a right. But my way of doing it, so McMurray's is the test for meniscus. Okay? So it's a provocation test. We're trying to make it hurt to confirm the presence of a meniscal injury. So I tend to flex right up, and with my hand either side of the joint, so on the joint line either side, I'm flexing. A little clunk there. Yeah. Give me this one. We're doing internal and external rotation of the hind foot. Okay, and we're looking to see if it hurts the patient, and you're feeling for a clunk either side as well. Okay, so that's how I do the McMurray's test. I know there's an at-place test where you get to roll on the tummy, you can bend the knee up and you can grind down. I don't do that personally, but on the occasion if I'm not sure and I don't get the McMurray's, I've done it and occasionally it's been positive, so there we go. So that's McMurray's. Right, the collateral, so this is important. So when you're testing the MCL, I tend to stick the ankle under my armpit there, and you have the knee at about 15 degrees of flexion, okay? And then what you're doing is you're putting a valgus strain on it, and you're measuring that against the other side. Now the varus way is a bit harder, so you're stressing the lateral collateral. There's a lot more natural laxity in the lateral side. Okay, so tension down. But you have to, I put my hand behind the popliteal fossa, nice and relaxed, dead. And I'm just doing that, I'm measuring how many millimetres of opening there is. Okay? And again, you must always compare the other side. If you have the knee in full extension, the screw-hole mechanism of the knee, condyles will give some sort of restraint. If you do full extension and then examine the MCL, if it opens there, then that's a significant injury. That means the deep oblique ligament behind the back and the capsule have almost certainly been injured as well. So that's a much more significant injury. Okay? But normally it's in 20 to 30 degrees of flexion for the MCL and the LCL, post-ruptural corner. Right, ACL. So the anterior and the posterior draw. So you've got to make sure their foot's not hurting and then warn them you're going to sit on their foot, so you're going to sit on your foot. Okay, and just basically stop it from sliding forwards. Make sure that the hamstrings are nice and relaxed, so you just get them to settle down. Now, your thumbs go on the condyles of the femur, okay? And the thenar eminences of here are on the proximal tibia. So I'm pushing backwards to assist the PCL, that's the posterior draw. And you're putting forwards for an anterior draw. And as I say, I only reason you use it for PCL if I'm worried about the PCL. The ACL, the Lockman is my workhorse. So I've got to get nice relaxed, I stabilise the thigh with my left hand. And then I've got the proximal tibia in my right hand. In the direction of travel, I'm trying to pull Ted's shin over my shoulder. Okay? So that's the, I don't know if you can, maybe you're in the best position to see, that the tibia, relax. If you shout relax at someone, it tends to relax. That's the locking test that I do. And you have a locking test for the ACL and the PCL. So coming forwards for the ACL and going backwards for the PCL. Okay? And then the pivot shift, so Ted's ACL is intact, we just found out. But the pivot shift, you have to extend the knee, a slight internal rotation at the hip, and I generally do it like this, and you've got to put valgus on. In that position, if Ted's ACL had ruptured, he would have already a partially dislocated joint, and his ITB would be in front of his mid-flexion point. And as I flex his knee, the ITB jumps backwards and the joint pops back into, and that's the clamp that I showed you in the video. That's the knee relocating. That's what a pivot shift test is. You're relocating a dislocated, partially dislocated knee, and that's how we do it. And Ted's got a normal ACL, even he finds it. So you can see it's not a very nice test to have. This guy, MCL, LCL, PCL, ACL. Anything else?
I've tested previously in patients who had meniscus problems, and I'd done similar test to you. And it wasn't aggravated, but because the problem continued, I asked them to see a consultant, and they actually had meniscus problem. How many times would you have this happen to?
So yeah, I often get surprised, maybe 10-15% of the time. So it's quite, you know, it's not a very sensitive test. So what I mean is there's a lot of false negatives, okay? High number of false negatives. So that is right, isn't it? False negative, yeah. So, you know, wiggle them around, not very much, but you're convinced in the history, you know, this classic meniscal sounding pain, it's in the same location, they start after a sort of twisting type pattern, there's a age group for it, they say the knee swells occasionally, they don't like deep squatting, you think this is a meniscus. You examine them, there's nothing to find. So you send them for a scan, and lo and behold, here it is. So it's not assessed. If there's a pivot shift, it doesn't matter what he tells you or what the scan says, that ACL is not functioning. So even if you've had someone who's had an ACL reconstruction, I get them from other places, and they injure the knee skiing or whatever it is, and they say the scan says, "Oh, I've had the scan and thankfully it's okay." If you do a pivot shift and it's positive, whatever that graft is in there for, it's not holding the knee steady. So it's a very sensitive test, and you can see that it's not working, I'm afraid. So that's why, especially for ligaments in the knee, examining is so much more important than doing a scan.
Can you aggravate more by doing this test?
Look, I think if you were going to, I think you can cause damage by doing the test. If someone's got an unstable bucket handle tear, and I've managed to lock someone's knee before, that was embarrassing, but that was only once. So somebody who's got a classic history of an unstable tear, popping in and out, so they'd say something I just can't straighten my knee and then it goes away again. I think that's something strange, and I've examined and done them at McMurray's. They've got the catch on the flames, not doing it. So you can do that, I suppose, but no, I don't think you're going to irreversibly do any long-term damage, even if they find it uncomfortable.
And, sorry, another question, how quickly would you ideally get them onto your table?
So in an ideal world, as soon as the range of motion is restored,
Okay.
so whatever that takes, 2-3 weeks is the quickest, and 9 months is the longest. In fact, I've just been at an ACL symposium last year before Christmas, and the Austrians, who are looking after elite skiers, are operating within about 4 hours of the injury. Okay, so they've got this complex in Austria that they've built. So they've got a helipad on the top floor, they've got an MRI scanner on the fourth floor, they've got the consulting suites the next floor down, the operating suites the bottom, and the Visa card machine, and they are literally operating within hours of the injury. On these, I mean, we're talking elite skiers, so people have got coming with quads this size anyway, and they've reported no. So the big sort of no-no about operating too early with ACLs is the arthrofibrosis. Okay, so a horrible condition where you have a stiffness, often untreatable stiffness in the knee. And it's thought to be operating too early after an acute injury. So big hemathriosis, all the inflammatory mediators in the joint, if you then go in and further insult the knee by operating, you can cause this terrible stiffness. And So they were sort of presenting this data, and it was quite good data, sort of display that myth. So I think that that's okay if you get them within an hour or two, but the problem is if you get them in a week or two. You know, that seems to be the danger time. So I would say, you know, I send people away with a stiff and say, go and see an osteopath, see a physio, get your range of motion, and then we'll talk about doing the operation.
And how fast after operation do you think hands-on manual therapy should be conducted?
So I don't think there's any, so it depends what we've done. So if I've done a meniscal repair, I like bracing them for 6 weeks, not to 90. So they can go up to 90 degrees, I just don't like them going beyond 90. And the reason is that most of the meniscal repairs I do are at the back, and when you flex, you know, up to 120, 130, I mean, nobody can do that after an ACL for the first couple of weeks anyway, because the knee's swollen. But you really stress the repair, because remember, the menisci are mobile. And if you look at a dynamic MRI scan, if you go to a deep squat position, I mean, your lateral meniscus has disappeared off the back of your tibia. It's almost down by the PCL. It's very mobile. So if you've done a big repair on that, you don't want to stress those stitches. You want to give the biology a chance. So that's why I brace them on for 6 weeks, up to 90 degrees. They can weight bear. So as soon as they put weight on, that's fine, because the hoop stresses actually help the thing knit together. But I don't want to do deep flexion. So with that in mind, you know, you can't damage the graft by getting them moving early on, as long as there's not a meniscal repair at the same time. You know, the hands-on therapy. You know, I keep closed. Well, I mean, Kathy, you guys with the hands. What about closed chain, open chain? Do you have a big thought on that, Kathy?
Yeah, we do all closed chain for ACLs.
What, first couple of months?
Yeah.
But your actual hands-on, you know, deep tissue massage, work on the hammies, go for your life, nice and early. You can't damage the graft at that stage.
We see them within a few days. They're coming back in throughout Christmas.
Kathy was like, most upset if you haven't seen them in the first week.
What about braces, like being unhelpful?
So for ACL injuries, so I would brace someone acutely if they had an MCL injury. So you remember to stop them extending fully, so to protect the MCL to let it start healing. And I would brace them after the operation if they've done a meniscal repair. But I can always tell if I brace someone at 6 weeks because their quads are nothing, they've still got an effusion in the knee, and there's a huge difference. So without a doubt, getting them going early is beneficial. But you've got to, it's a toss-up. You know, you can't let them go too early if you prepare the meniscus, otherwise you're going to undo good work. But it's so obvious to me when I brace them for 6 weeks, when they come back with this 6-week follow-up, just how diminished their quads are, and they've still almost always got an effusion in the knee. And you guys probably noticed that. I think
Pre-surgery? Before?
so bracing, so you're absolutely, I mean, everyone comes back from A&E and the ARC with these extension splints, so there's cricket pad splints, or cricket bat splints, as some people think they're called, but I don't know what that is. But anyway, so extending your knee in a brace is possibly the worst thing you can do for it. I mean, it just doesn't make any sense. And I'm trying to get rid of the extension braces in casualty, because they just switch off your quads straight away. They make you stiff. Stiffness makes you painful. Painful makes your quads go down. And it's just a vicious circle. And you know, I see, especially patella dislocations, you know, they do not need bracing. Okay, I think everyone's fear, because it must be a horrible. I've never dislocated my patella, but it's probably a horrible thing. But I think they get put on because they feel they're doing something in casualty. Here's a brace, you know, had a big injury, and the patient, oh my god, you know, there's a brace, just get my kneecap, and it might pop out. But they don't keep on popping out acutely. They have the injury, it either self-locates or someone else does it for them. They don't then just pop out, and that's very rare unless they've got a gross abnormality. So range of motion nice and early, getting the fluid out and keeping the muscles active. Because otherwise, you know, when they come, you see me at 2-3 weeks down the line, 4 weeks down the line sometimes with a brace on. You know, and tears will take the brace off, and they've got, you know, 20 degrees of motion in the knee. So, in answer to your question, Jude, I hate braces for almost everything. I mean, if you repair a quads tendon or a patella tendon and you're worried about it or something, that's different. But even then, you know, 2 weeks maximum. Movement is key. Once you lose your quads, it's an uphill struggle. All right, Dad.
Thank you so much. Thank you, everyone.